Good morning, everyone, and welcome to today's COVID-19 Community of Practice for Ontario Family Physicians. The Department of Family and Community Medicine at the University of Toronto and the Ontario College of Family Physicians are pleased to continue to offer these sessions to our community. And we're really excited about today's session, which is focused on COVID-19 updates and the new Ontario Structured Psychotherapy Program. I'd now like to turn things over to Dr. Mekalai Kumanan to open up the session on behalf of the OCFP.
Good morning, everyone. Welcome. I'm really happy to be here with all of you. And like Ali said, we have a great session ahead. I'd like to just take a moment to thank our speakers for being here with us today. And a reminder that this is a Main Pro accredited session and details will follow. Next slide. So just moving on to our land acknowledgement. We acknowledge that the lands on which we are hosting this meeting include the traditional territories of many nations. The OCFP and DFCM recognize that the many injustices experienced by the Indigenous people of what we now call Canada continue to affect their health and well-being. The OCFP and DFCM respect that Indigenous people have rich cultural and traditional practices that have been known to improve health outcomes. I invite us all to reflect on the territories we are calling in from as we commit to gaining knowledge, forging a new culturally safe relationship, and contributing to reconciliation. And I'm calling in from Kitchener, the lands traditionally used by the Haudenosaunee, the Anishinaabe, and the Chinantan peoples. Next slide, thank you. So I'll just take a moment to reflect. This is a story from my region, actually, that I found very, very uplifting. So for those of you who don't know, last week was Treaties Recognition Week in Ontario. And in 1613, the Two-Row Wampum Treaty was signed on the lands traditionally used by the Haudenosaunee. And essentially, this was an agreement between the Haudenosaunee and the Dutch settlers that was founded on the basis of respect between the two nations. And so to recognize that treaty, every summer, a group of Indigenous and non-Indigenous people participate in the Two-Row on the Grand, which is essentially a 10-day canoe trip down the Grand River and is a reenactment of that treaty. And throughout the trip, the group stops at communities along the way, and they hear from speakers each day, which include Indigenous historians and residential school survivors. And what struck me, I think, the most about this story was hearing the participants' reflections on their journey. So some of them described it as a means of building trust, as a way to take action to gain a deeper understanding of the other's culture, and a way to develop a spiritual connection to the land as they made this journey together. Next slide. Back to you, Ali.
Great. So in terms of this particular session, just so people are aware, you'll be able to access links to the session after it's completed, and it is Main Pro accredited, and we will all be going through financial disclosures as well. Next slide, please. And so we're so thrilled to have three amazing panelists joining us today to provide our various updates, and I'll have them introduce themselves shortly. Next slide, please. Next slide. All right, so now is the time for each of our speakers to introduce themselves. So we'll start with Dr. Gerald Evans.
Hi, yes, Gerald Evans here. I'm an infectious disease physician in Kingston. I work at Kingston Health Sciences Center, and I'm the head of the Division of Infectious Diseases at Queen's University. And as you can see, I guess one of the most important ones to point out, I did go to Australia recently where I gave a number of academic talks, and including a talk at their major vaccine conference. And my trip to Australia was supported financially by Moderna.
Okay, thank you. Next over to you, Paul.
Yeah, hi there. And I've been told that my screen is flickering, so if you see a little red flicker, I apologize for that, but I'm hoping you can hear me okay. My name is Paul Kurdyak. I'm a psychiatrist at the Center for Addiction and Mental Health, or CAMH. I'm also lead of the ICES Mental Health and Addictions Program, and Vice President Clinical with the Mental Health and Addiction Center of Excellence at Ontario Health. Happy to be here, and as you can see, I lead a pretty boring life and have no conflicts to speak of.
Thanks so much. Over to you, Leah.
Hi, everyone. I'm Leah Skory. I'm a family physician with the Barrie Community Health Center, and I do receive some honoraria for various speaking engagements with different organizations across the country, usually around self-compassion and compassion in healthcare.
Over to you, Dr. Kumanan.
Thank you. Hi, everyone. My name is Mekalai Kumanan. I'm a family doc in Cambridge. I'm currently serving as the president of the Ontario College of Family Physicians, as well as the chief of family medicine at the Cambridge Memorial Hospital, and neither of those positions poses a conflict for today.
And for everyone here, I'm Damji. I'm the moderator of today's session, and I receive honoraria from the Ontario College of Family Physicians, and I also work as division head of primary care at my hospital, Trillium Health Partners, and also do some work with the Ontario Medical Association section of General and Family Practice, none of which pose a conflict for today's session. So in terms of some housekeeping rules, in terms of how to participate, remember that we do have the Q&A function, and you can use that function to ask your questions. I already see some of you have figured that out and already started posting some questions, which is great. If there's a question that you like, please use the thumbs up button to upvote those questions, because that prioritizes to me as the moderator which ones should be asked. And then again, a reminder that the chat function, of course, is something that we welcome you all to use, but please do not ask questions through the chat function. It's difficult for us to see those. So please, if you have a question that you want to ask the speakers, please put them in the Q&A. And before you put it into the Q&A, check to make sure someone hasn't already asked the same question. And if they have, just upvote it to, again, make it easier. Next slide, please. Okay, so in terms of the format of today's session, I just wanted to quickly update you all on something that we've changed in response to the feedback we've received. So we've received some feedback that, the preference is to try and get the core content done by 9 o'clock because people often have commitments right after these sessions conclude, understandably as busy family doctors. So what we've done is we've taken that feedback to heart, and our plan is to shorten some of the Q&A between the sessions, between each speaker, but then have a longer Q&A at the end of the session starting at around 9 o'clock. So I'd liken it a little bit to your days in medical school when people used to hang out after the lecture and talk to the speakers. That's what we're planning on doing, but in this virtual format. So there will still be that Q&A, but we're just planning on having the bulk of it to happen towards the end of the session to allow people that need to leave the opportunity to leave. And we look forward to hearing feedback on this. It's a new format for us, so please fill out the surveys so we have a sense of whether or not we got it right. Next slide, please. I'll turn things over to you, Dr. Evans. Thank you.
Thanks very much, Ali. So I'm just going to give a very quick and brief update. I've tried to answer already some questions in the Q&A just because they're popping up fairly fast. So this may be very appropriate in terms of the next talk, this little cartoon, which I found, which we know certainly COVID has not left us at this point. So next slide, please. So let's go over some quick things on laboratory confirmed weekly case counts. This is updated every Friday by the province. So today's graph will look a little bit different than this one, but what you can see is there's been a steady rise in cases since the late summer, early fall. There was a little brief lull, seeming dropping off at the beginning of October, but that's increased again. So we are still facing this upsurge of cases, which started a little bit earlier than what we normally see with respiratory viruses. Next slide, please. These are weekly confirmed outbreaks, and what you can see from here is that we're looking at these are outbreaks that are happening in congregate living settings and in hospitals where they're currently tracked. And what you see here is we're up to the same level of outbreaks that we were seeing back in the early part of January of this year. Each of these graphs, as you can see, is starting at the beginning of this calendar year. So that tells us that there is ongoing community prevalence of the virus, and we're hoping to see a downturn in this. And I've certainly seen it where I live in the southeast part of Ontario. Now that we're rolling out and have rolled out vaccination, particularly to these vulnerable populations in congregate settings. Next slide, please. This is a graph of test positivity from the network. And if you ever go on this site, you have to be very careful. You're looking at the network data versus just public health lab data, which is much higher. And that's because they are getting a lot more tests being done on high pretest probability individuals. So right now we're sitting just at about, somewhere around 16, 17% test positivity. The province considers that to still be a moderate category. I would call it actually relatively high because I think 15% is a better threshold. Next slide, please. So if you want to kind of put test positivity into some perspective, one way you can look at it is, how does that convert into sort of a transmission risk? In other words, the risk of transmission. And what you can see on this slide is actually what the province has determined to be their threshold. So they have 20%. My little red line is a little bit below the 20% line there. But you can see that as far as the province is concerned, at the moment, we're in a moderate risk category, because I think 15% is the threshold. I would actually put us just over that and into a higher transmission risk at the moment. But you can see that during the summer, we had a nice lull. We were well below 10%, and in fact, below 5% at some point. So there was a lull, as one would expect with some of these respiratory viruses during that sort of seasonal reduction. Next slide, please. So let's talk a little bit about where wastewater is going. This is the most up-to-date data that we have, with the graph on the right representing a little bit of where the trend is heading. So you can see we've had this gradual swing of the wastewater signal, which is looking for the RNA of the SARS-CoV-2 virus in wastewater across Ontario. There are regional differences right now. In particular, I can tell you that the southwest, which would include Hamilton, Chatham, and those areas, has actually got a slightly steeper curve. This curve mimics what we're seeing in the GTA, which tends to dominate the signal. But it does suggest that we are still ongoing with an increasing number of cases. Since this is a really kind of an early warning system, it gives you about a 7-day lag until you actually see the actual numbers rising. Next slide, please. So right now, this is my take on things. I think outbreak numbers are sitting kind of in that amber alert. I'm using the traffic light system. Test positivity, according to the province, is still moderate. Wastewater, though, is rising again, and I think that's telling us that we are moving into a potential for higher prevalence and higher rates of cases, at least as of today. And we have to just kind of continue to watch that. The interesting thing is that they're starting to become now an early influenza signal. And last year, we saw viral interference. When influenza went really high along with RSV, there was actually a drop in COVID infections. And that's probably something called viral interference at effect. All right, next slide, please. So just so everybody knows, so just to put this in context, this is the variant testing. We do genomic testing at four sites across the province, where all isolates are genomically tested. Where I work here in Kingston, our laboratory actually is one of the 4 sites. What you can see here is that it's all XBB recombinant. So XBB recombinant has arisen and is dominated now pretty well through all of 2023. Various types of XBB, they're all BA2 recombinants, but this is really important because it's going to segue into the discussion quickly now about vaccine, because as everyone knows, since early October, we've had the availability of the new XBB vaccines, currently a monovalent one. And really that's right now the answer to sort of controlling everything as it moves forward. So next slide, please. So a lot of times I get asked this question about, well, if I get vaccinated, how long am I protected for? In previous talks I've done, I've talked a little bit about the difference between sterilizing immunity and protective immunity. But this is actually from a very interesting study during the Omicron era, looking at vaccine efficacy, which about a month out after being vaccinated, this is protection against symptomatic disease. So this is a bit of, if you want to call it, sort of sterilizing immunity, and it's at about 60%. Protective immunity, of course, is much higher early on, about 80 to 85%. But what you can see at 1, 3, 6, and 9 months, which is where you're going as the slide goes down, is that begins to wear off. And by about 9 months, the protection against getting infected, if you've been vaccinated, or getting symptomatic from an infection when you get vaccinated, has now dropped to below 20%. So that's part of the reason why there is a recommendation looking now generally for the population that have a new vaccine every 6 months. And if you're young and healthy, you could probably extend that out a little bit further. Next slide, please. So the other thing, of course, that we're recognizing, and I know that some people don't like the term hybrid immunity. I mean, it's immunity to the virus. What they mean by hybrid immunity, though, is immunity that's arisen from vaccination as well as infection. And what we know is that that protection, which is offered from having an infection with SARS-CoV-2, does produce antibodies against various other proteins, nucleocapsid-coded ones, versus just the spike protein, which is what you get from the vaccine. And so In essence, that combination seems to produce a more durable response in terms of immunity, both protective and sterilizing immunity from the virus itself. Next slide, please. So a lot of people have been asking questions about how good are these new XBB monovalent vaccines. So this slide just looks at all of the various vaccines that we've had. And what you can see at the bottom is the XBB.1.5, which is the current monovalent mRNA vaccine offered by Moderna and Pfizer, and it will be available from Novavax 2 as a recombinant subunit vaccine. So what we know from preclinical data is they look just as effective as the previous ones, particularly against the currently dominant circulating variants that are out there. So the question everybody's asking me, though, is what about the clinical data? And we're still collecting that. There are human trials still going on, and we're looking at those clinical outcomes to determine if they're similar to what we saw with the previous vaccines, and they probably are. Next slide, please. So just very quickly, this is efficacy measured by neutralizing antibodies. And we do know now almost 4 years into the pandemic, that the height of neutralizing antibodies measured in people who get the vaccine is a good surrogate marker of protection, both from infection and ultimately from severe outcomes from infection. And what you see in here in green are the monovalent. This is the Moderna vaccine, and you can see that there produces a substantial boost in neutralizing antibody response, very similar to what we saw with the other vaccines. The challenge that we have is that we don't have the clinical data at the moment to really be able to support this, but it looks like it looking at some of the interim data, which is in pre-publication. Next slide, please. This is the Pfizer XBB vaccine efficacy, and you can see exactly the same effect. It's comparing the original vaccine to the XBB.1.5 vaccine, or the original plus BA.4/5. So it's the bivalent that we were using last year. And it gives much higher levels of neutralizing antibodies against the XBB.1.5. Right now, of course, the dominant XBB is a 192 variant, principally at the moment HV1, which is just a shorthand for an XBB.192. Next slide, please. What about safety? The only thing that's interesting here is that it's very similar in terms of the local and systemic adverse effects that are seen with the vaccine. There is a suggestion in this would be non-comparative data, taking data from the previous trials and this trial, is that there are probably a little bit higher rates of local reactions, particularly at the injection site, that are being reported with the monovalent vaccine in comparison to others. But no grade 4, which are very bad reactions to vaccine, and no serious adverse events. Now, that's just an interim analysis, and it's in people who have been given this particular vaccine as a 5th dose. Next slide, please. So on that point, I know there's a lot of questions that I'm still getting, and that we certainly get through various means about what do you do with antivirals, outpatient use of antivirals in adults with COVID-19. So right now, we know the primary determinant of bad outcomes is age, advancing age. And so what we are doing at the moment is taking anybody who's at risk, and we do have a list that's been published of people who are at risk, which includes mostly older people, but people with a number of different underlying disorders. And if they are at high risk for hospitalization or death or worse outcomes, we do recommend antiviral therapy. If it's been less than 5 days, and primarily for most people, we prefer them to get Paxlovid, which is nirmatrelvir and ritonavir. However, as many of you know, there's lots of drug interactions, and so this can be challenging in older individuals. Many of our patients are on multiple other meds. Since it's a short course, though, you can do some short course modification, and the pharmacist can help you with that, and we prefer to you go that route. If, however, it's been more than 5 days, the alternative can be the use of remdesivir, because there's a window of 7 days for remdesivir, solely based on the clinical trials. And the only challenge with remdesivir is it's intravenous. There is a program out there now which allows for access to community care to get IV therapy, but the real challenge is in long-term care. In long-term care, that can be extraordinarily difficult to do. And so we are reverting sometimes to reaching out to my colleagues in infectious diseases, but also a number of the general internists that have access to hospital facilities, which would allow you to give a remdesivir infusion. And so we are supporting the use of remdesivir. This is all basically to prevent hospitalization, because that is really the challenge that we continue to face in the pandemic. And since the rise in cases that we've been seeing, we have seen an increase and a steady rate now of people who are admitted to hospital with COVID, and again, principally older individuals. Next slide, please. I think that's my last slide. Yeah, it is. So back to you, Ali.
Thank you so much for that amazing talk. It was very comprehensive. So, we heard a lot about the current illness patterns that we're seeing, the prevalence. You really highlighted some interesting new concepts like viral interference, and I see some questions about that as well. And also highlighted elements around the efficacy of the vaccinations and the treatments as well, too, and given us some updates on that. So thank you for being so all-encompassing there. So I'm going to turn things over to some Q&A. Gerald, I'll actually ask this one live. I think you're about to type an answer to it, but I'm just going to ask it live because I think people are going to want to know the answer as well in case they're not at their computer screen. So right now, is it safe to be indoors in crowds without a face mask in major cities like Toronto or any type of densely populated area?
Yeah, I don't want to be a lawyer, but I want to say define safe. There's lots of other things that can happen in crowded indoor spaces. I know it's about COVID. Right now, prevalence is up there. And so there is a substantially higher risk if you're in an environment where it's crowded, it's indoors, there's not a lot of ventilation going on. And so not wearing a mask will allow for that risk to increase. Masks work. Despite the Cochrane review, which Cochrane, of course, as everyone knows, has backed off and said it's really about prompting people to wear a mask. So wearing a mask will reduce the likelihood of transmission by about 50%. If you wear a really high efficiency mask, that goes up a little bit. Whether it goes up a substantially larger than 50% is still a matter of debate, because we don't have non-comparative trials, because nobody wants to do them, because everybody gets mad at them. So yeah, it's a little bit risky at this point because there's prevalent virus around. And of course, once influenza hits, you're going to see the same thing. So be careful when you're out there. I think that was an old line from a TV show when I was a kid that the sergeant said to all the cops as they were going out for their beats.
So my next question for you then, which maybe dovetails well with what you just said, is how much of a problem is long COVID right now?
So current estimates in the Omicron era is that it's about, for most adults, it's about 6% of people seem to go on to prolonged symptoms that last longer than 3 months, which can be loosely defined as long COVID. As everyone knows who follows this carefully, we still lack a good definition, and that relates to how long after you've had COVID and what those symptoms are. So there's a general perception that anything after 3 months that involves some of the more typical kinds of symptoms, which are oftentimes for some reason cognitive and related to fatigue, that's about 6% now. It was higher in the original ancestral virus and Alpha and Delta eras, but it has come down substantially. A lot of that may be due to the effects, obviously, of vaccination. We know vaccination actually does reduce long COVID. There are now at least 4 studies that have shown that vaccinated individuals have a lower incidence. So it's out there still, but lower than it used to be.
Great. Thank you for that. So our next question here is, if patients didn't get the new vaccine and they just had COVID, what's the recommendation for how long they have to wait before they could actually get the new vaccine?
Yeah, great question. The answer is about 6 months. So we have a really good study, and then a couple of studies which have reinforced the point that show if you get the vaccine within 6 months of infection or within 6 months of your last vaccination, the immunogenic response to that dose has actually really knocked down. So it's not harmful to get the vaccine within 6 months of an infection or having a vaccine, the previous vaccine. It's just you don't get the boost that you want to get. And so that's why the recommendation that's out from NACI and many other groups is to wait about 6 months after you've had an acute COVID infection or you've had your last vaccine until you get your next vaccine. And I'll just add on, because I've seen a question about this before too, is that some people are recommending a shorter interval for, particular individuals who may be at high risk, because we know that immunogenic responses in older people and people with underlying diseases where there's an impairment of immunity, either from the disease or treatment, that you might consider a shorter interval. Not well studied, but certainly some of my colleagues have been recommending that, and I've certainly done that myself.
Thanks for that. And maybe to take that question also in a different direction, I see another one that's somewhat related, which is, for individuals who are over 65 who remain COVID naive. Now, I think those are in some ways almost unicorns because it seems like almost everyone's had COVID at this point. But let's say, someone who hasn't had COVID at all. Would you recommend boosters at a 4-month versus a 6-month interval, given that they don't have that hybrid immunity that you spoke about earlier?
Yeah, so one of the interesting things, if you are, these people, by the way, call themselves novids, not COVIDs, novids, that you're doing lots of obviously good things, or there's something about your life that has allowed you to avoid becoming infected with this virus. I would still recommend 6 months because you're probably doing lots of stuff to be careful out there. In other words, all of these non-pharmaceutical kind of interventions that are there. So I don't think there's an advantage to every 4 months, because if you're relatively young and healthy, and I mean a 50, 55-year-old person without any medical problems, getting a vaccine less than 6 months apart is not going to give you the boost that you expect. So you really want to get that boost effect, and that happens at about 6 months since your last vaccine.
Great, thanks for that. Going back to some of the data that you presented, you talked about the wastewater signals, you talked about the transmission risk, but in terms of deaths, what is that looking like now compared to previously with this new variant?
Well, this is the thing. Are people still dying of COVID? Absolutely. Are a lot of people dying of COVID like they did? Not at all. So the real part of the success of vaccination has been to take, people who were almost certainly going to die. I mean, we were looking at case fatality rates in older individuals of about 20 to 25% in the early stages. Those are now down around what we would see with seasonal influenza. So that's really been the effect. So yes, there are always anecdotes of older people who are fully vaccinated who die, but the vaccines have dramatically changed that. I just want to add one thing because I think I saw something pop up. So the Canadian Blood Services study that looked at seroprevalence of virus to determine who's not infected in Canada. Now it was data from earlier this year when it ended. There were still about 20% of the population that have not had COVID, as measured by the lack of nucleocapsid antibodies in their blood that are being donated. So novids are not as rare as we think they are. In other words, at that point, at least about 1 in 5 people. I would suspect now we're probably getting down to 1 in 4 or 1 in 3 people haven't had COVID. So yeah, they're out there.
That's great, and that's something I learned today too. So thank you for that. In terms of the concept of viral interference, that intrigued a few of us as well, including myself. So we were wondering if you could explain that a little bit more, that term.
So one of the things that's been noted in vitro experiments and looking epidemiologically is that when you get a viral infection, it seems to prevent another virus from coming in. Now, having said that, co-infections happen, sure. But there is some fairly good data to suggest that when you're infected with one virus, whether it be influenza, RSV, even a rhinovirus, there is a turn on of a system in the immune system, typically what we call type 1 interferons, which help to have that first dramatic effect on reducing viral replication. If that gets turned on because you have the flu, you've just been infected with influenza virus, then if a SARS-CoV-2 virus comes walking along and tries to jump into your cells, it faces basically a whole turned on immune system in the intracellular compartment and seems to prevent that from establishing an infection. So viral interference, certainly a well-known phenomenon. We know co-infections happen, but they're relatively rare. The question is, which viruses are more effective at producing viral interference? And we know now from last year's epi data that influenza and RSV seem to be really important in reducing COVID to some extent. But rhinoviruses, which pop up in the fall, actually probably have an effect too. And that little lull we saw in early October was probably just because that was the peak of the rhinovirus surge that we see every fall.
Great, thanks, Gerald. I'm going to ask one more question before we turn things to the next speaker, and then we're going to come back to you as well too at the end of the session. So this question, essentially, I'll read it out because there's a bit of context behind it. So this physician's talking about seeing more COVID in their patients now than they have all through the pandemic. Granted, because of immunization and prior infection, like you mentioned, people are getting more milder or moderate disease, but not all. Some do get very sick and some have long COVID and symptoms for months. But the question pertains to the fact that it seems as though the public isn't really thinking about COVID anymore. There's less, emphasis on masking, not staying home when they're sick, not testing for COVID with their rapid antigen tests. And so the question is, in your opinion, what's your advice for how we can get people to buy into these simple principles still when we're living in this context where it's almost normalized?
Yeah, that's a good point. So really, and I've been a bit of a critic of the fact that the messaging that's coming out tends to be political, which is, COVID's not a worry anymore, or we have to live with COVID kind of idea, because these are sometimes fairly basic, simple things to do. Wearing a mask is not particularly onerous if you're out at the grocery store or out there wandering around. If you're outdoors, I don't think you have to wear a mask, because there's no way. I mean, we showed that on the science table, that if you're in the outdoor environment, you don't need it. But yeah, there's lots of fairly simple, straightforward things that you can do to do that. And I think the number one, Ali, of the ones that were mentioned in the question is staying home when you're sick. We still have people reverting to old behaviors. We all did it. You have a cold, you say, it's just a cold. I know it's not one of those bad ones because I don't feel really terrible. And you go to work. Well, then you're infecting your coworkers. Right now, staffing in healthcare is a huge problem. And the last thing you want to do is to create that. So the other question I'm getting asked a lot is like, if you guys have offices, should people be wearing masks? And the answer is, yeah, I would recommend it. Masks have a easy, simple 50% reduction in the likelihood of transmission risk. We're back into sort of the kinds of prevalence we saw last winter. And I think most of you, if I think about last January or December of 2022, you were probably still masking in your clinics. You may have reduced it, and I would certainly have advocated for that during the summer. It was a real lull. We didn't see very much of anything. But right now, yeah, you should be doing that. I think that's really important. And it helps to prevent that kind of ongoing transmission risk, which we know rises as the respiratory season comes on.
So then actually, Gerald, I might squeeze in one last question, because I know this is going to be at front of mind for everyone as we're getting into the holiday season. Work, Christmas get-togethers, holiday get-togethers, and things like that, especially in the healthcare setting. What are your thoughts on that? I'm curious.
Yeah, it's really challenging. I get that asked a lot in the hospital, because people who want to gather during the holiday seasons often are like people from one of the hospital units or something. And I imagine if I had a community practice, it would be the people in my office. I want to bring them and their loved ones and others together to celebrate the holiday season and being together. Well, the challenge there is that if there's a transmission event going on in that, it's going to knock out your whole clinic, right? So yeah, that's the hard part. So certainly doing everything you can. We've been really lucky. I think today it's about 12 degrees outside here in Kingston, but then we're getting the wind off the lake, which always warms us up. If you can try and do those gatherings a little bit earlier, I think we're a little bit on the upswing for COVID. And as I said, flu is showing now finally the early signs that it's coming on. Maybe have those parties a little earlier. Try and do them in a little bit safer environment. Maybe not bring the entire staff over for something, but then of course somebody will feel left out or whatever. But yeah, those are ongoing challenges that we have, and particularly as we're transitioning out of the pandemic of COVID-19.
Great. Thanks so much, Gerald. So we'll come back for some more questions as well. So stay tuned to the audience. So next, I'm going to turn things over to Dr. Kurdyak.
Thank you. And Dr. Evans, that was a great overview. I'm here to talk to you about Ontario Structured Psychotherapy Program and what we're developing. But first, I want to provide some context, and it has to do with the work I do as a psychiatrist, but more importantly, the work I do sort of studying the system. Well, I don't call it a system. I call it a sector, the mental health sector as we know it at ICES. And what I see is what you experience, which is primary care physicians are doing the heavy lifting in terms of the provision of mental health supports to Ontarians struggling with these conditions. And what the data shows, what you experience day to day, which is that there's not really much of a system to speak of to support you in your work that you do with these individuals. And so the Ontario Structured Psychotherapy is one of our first forays into building systems of care to support you. By no stretch of the imagination does this cover all of the needs you would have in terms of the support that you would want in terms of with the work that you do, people struggling with mental illnesses, but it's an important start. So I kind of want you to think about that as I go through my presentation. Next slide, please. So what is the Ontario Structured Psychotherapy Program? It is free access to cognitive behavioral therapy and CBT related services. The program provides individual and group CBT. They also have what are so-called lower intensity services that provide us with high volume propositions in terms of access, which is bounce back, clinician assisted bibliotherapy, which is basically self-guided with a coach working through a CBT workbook, and more recently, internet-based CBT. It is serves people 18 and over, and it's a low barrier service, but we're trying to create measurement infrastructure to ensure that we are reaching the individuals, all the individuals who need it, because we know that when we roll these kinds of things out, typically the rich get richer and some people get left behind. So we're thinking through how to ensure that we are reaching the people who most need it. It's based on a hub and spoke model. We have 10 hubs that now cover the province, and we now have about 100 community-based services that interact with the hubs in terms of oversight and kind of blanket the province now. And we are figuring out with an excellent team how to adapt the services for Indigenous communities and individuals so it's culturally safe and appropriate. It is a step care model, which means that people tend to start, we match people with need, but people tend to start mostly in the low intensity service. And then on the basis of measurement and response to treatment, get pulled into higher intensity services. And this is really important. Every provider who's working in our program has received training so that no matter where you are in the province, the services that you are getting are the same, which is, as you would all know, a pretty radical departure from the status quo. Next slide. This is the map of Ontario, just to show you these are the sort of the network legal organizations. I prefer to call them hubs, and the service delivery sites, I would prefer to call them satellites, but the hubs in the north, you see St. Joseph's Health Care Group in Thunder Bay, Health Sciences North, and in Sudbury. Sorry, we've moved on, a bit of timing. The point of the previous slide is that we've got the province covered, and there are many, many more satellite or service delivery sites attached to these hubs in the different regions that are providing these services. Next slide. I mentioned before 18 years of age and older, and we're hoping to lower that because of the need for especially anxiety related services for kids. And this is important. A formal diagnosis is not required, and it is you can refer into it as primary care providers, but it is also self-referral. And this was an important point for the program because of the high rates of unattached individuals in Ontario. We work with the clients to figure out the most appropriate service. And below you can see the in-scope conditions. I noticed before there was a question about who would not be eligible. We've tried to make it as inclusive as possible. So if somebody has a concurrent substance use disorder, it is not an ineligibility criterion, but severe substance use disorders would be an exclusion criterion, as would severe suicidal thoughts, just for safety reasons. Kind of the normal stuff, but we are really trying to make it a low barrier inclusive service by design. Next slide. So here's what you can expect. In the pink box, people can self-refer, or you will refer to the program. There will be an intake process, and people will either be deemed eligible and go into OSP enrollment or be deemed ineligible. And there's a bit of navigation to appropriate services if necessary, although that is a work in progress. Once they're enrolled, they get referred to either of the three low intensity treatments, which are bounce back, internet-based CBT, or the clinician-assisted bibliotherapy. And if they get what they need, they're done. If they don't get what they need, they are stepped up to either group or individual CBT. And certain individuals at the time of intake and triage assessment are deemed more appropriate for the higher intensity treatment because of baseline severity. Next slide. I think this is my last slide, just to say that it's really important that all of these services are behind a centralized intake and triage door. I know from your experience, which is my experience as an emergency psychiatrist, what's one of the difficulties with the existing system as it is that there are 100 doors to navigate. So everything around this program is behind this central door. From the client or patient perspective, it makes it really easy for you as referrers. It makes it really easy. Just send them to the program and we'll take it from there. From the provider in the program, it makes it easy because people just come and there's been a little bit of work to make sure that they are where they need to go. And from the program perspective, it's really important to have this behind the front door because it allows us to provide the most care in the most efficient way. And the main way we're doing this is to ensure that more people get to the low intensity services, which allow us to treat many, many more people because of the lower FTE burden associated with these programs. So we're doing population-based mental health care for the first time and trying to find efficiencies so that more people can get care. I believe that's it. I think you're going to move on to the next speaker.
Yep. So what we're going to do is we'll have both speakers present since they're similar topics, and then we'll do a Q&A for both topics. So it's my pleasure to turn things over to you, Dr. Skory.
Thanks very much. So I was asked to cover mental health in primary care in 5 minutes. So this is quite a challenge for myself. And what I wanted to do is just try and give some questions and strategies that you can use really regardless of what the diagnosis might be. And I wanted to start off with the WHO definition. So mental health is a state of mental well-being that enables people to cope with the stresses of life, realize their abilities, learn well and work well, and contribute to their community. And so with that in mind, I wanted to highlight how much we are helping our patients cope with the daily life stressors, even if they're coming in with a rash or they're struggling because their child is ill. Like we're dealing with this within primary care. Our longitudinal relationship with patients really allow us to create a therapeutic alliance, which is really a foundation to create a space where people can heal. And as we create these compassionate spaces, I also want to highlight that compassion is really the antidote to any suffering that may be occurring. So with that in mind, in this very moment, I invite you to consider all the care and compassion you have shared with your patients and in the world, and just notice what that feels like. And now, I invite you to imagine that all that care and compassion is coming back to you. And just be curious about what that feels like. Next slide, please. So one question that I often ask my patients after we've done a bit of a history, if they are coming in with some mental health concerns, is what 3 symptoms are you struggling with the most? Because there can be a lot that's going on. They're feeling overwhelmed. We might start feeling overwhelmed. And it just helps just to sort of narrow the focus a bit, because this gives us a framework for how to perhaps guide them in a direction and nudge them in, where they want to go in terms of what their goals. It also develops some self-efficacy. They have that own awareness of what's most important to them, what would be most helpful for them. And then as I see them in follow-up appointments, it's just a place to check in so that we can gauge, are we making some progress? Next slide, please. It's also helpful if this is something that you'd like to explore, is just to sort of see where they are with self-compassion. So I'll often ask, if a loved one was in the same situation what would you say to provide some comfort? So often answers will be, oh, I'd be really kind. I'd let them know that it's going to be okay, that they're going to get through this. I might even, give them a hug. I'd sit there and listen to them. And often patients would share that they'd provide to others a kind, soothing presence. And then if we follow up that question with, well, are you able to tell yourself the same thing? I will say like 90%, 99% of the time, they will say, no way, it's a lot different. And you may recognize this in ourselves as well, that we struggle to provide ourselves with the same kindness that we share with the world. And often with patients that are struggling with mental health struggles, with mental illness, that a lack of self-compassion is rooted with a sense of unworthiness or that they're unlovable. And that can often be from traumatic experiences, attachment issues, especially in their formative years as children and adolescents. Next slide, please. And then another question that I often will ask, and this is addressing more of their behavioral part. So if we kind of think of cognitive behavioral therapy, this would be working with the behavioral aspect. So if you are not struggling with blank, so let's say it's, with their fatigue or with their anxiety, what would you start doing today? So if you didn't have these issues, what would you be doing that you're not currently doing? And often they'll say, well, I would be going out for a walk, or I might be connecting with a friend. And so this is where you may work to develop a bit of an action plan to move them in that direction. Sometimes we can use the pillars of health to help guide us into like what area they would like to improve in. And I really try and have a conversation around nourishing our body. So again, it's sort of using that language with a self-compassion lens. So movement, nutrition, sleep, social, relaxation. And I just want to focus on relaxation for a moment, because this is how we balance our nervous systems. And we live in a very stressful world where our sympathetic system is activated from the moment we wake up, and if we're checking our emails or checking the news. And that's just inputting a lot of stress into our brains from the very beginning of our day until we go to sleep at night. And if you think of from an evolutionary perspective, we're really meant to have bursts of stress and then repair and relaxation. And so a lot of us in our society aren't really giving an opportunity for our parasympathetic system to get activated, where again, healing can take place. As you set perhaps an action plan with your patients around this, it's important to establish what their confidence level would be in that SMART goal that you can create. And if that person is not able to achieve a confidence of 9 out of 10, it's really important that you make the goal really smaller. So if any of you have participated in that 5-minute CBT course that's offered out of Dalhousie University, this was a really important take-home message. And if we're trying again to nudge our patients slightly onto a different trajectory, we really want them to be successful in the goals that we're helping them establish. And one way to do it is make the goal really small. So it could be before I see you next time, or on a Wednesday, at 9 a.m., I will go outside for 5 minutes, like a very, very small goal. Next slide, please. So I also just want to sort of try and broaden our perspective on mental health. And so when we think of, if we think of the word mental, that's pertaining to the mind. And if we think of the mind, it's actually consisting of our brain, our body, as well as the sensory data from the external world. And it's all integrated. We're learning more about the brain-gut connection, and there's referencing to how our gut is actually almost like our second brain, with all of the neurologic and hormonal interactions that are taking place. And we're also learning about the importance of the vagus nerve and how much of our bodies are under subconscious control. So it's also important to recognize that probably a lot of the physical symptoms that people might be experiencing, I think especially around digestion, that the source could be, underlying in from a mental health perspective. And I recently had a patient who's been struggling with frequent emergency visits for really serious, nausea, vomiting, abdominal pain that brings her into emerge. And she's been well investigated. And I said to her, well, if your mind was trying to tell you something about this, what would it say? And instantly she said, I'm doing too much. I've taken on too much. And so again, if we broaden our sort of mental health perspective, that we might be able to bring these aspects into physical symptoms as well. The vagus nerve plays a really important role in managing our organs, our breathing, our heart, our digestion. And so one way to help regulate our vagus nerve is through mind-body techniques. And so the breath is going to be probably the most important one. And I am starting to sort of educate people more and more now about breathing techniques to help regulate their nervous system. So if we're feeling stressed, but we start doing relaxation breathing, it's going to signal to our subconscious brain that there is no saber-toothed tiger in the room. We're safe right now. Other mind-body techniques will be things like yoga and any movement like Tai Chi or Qigong. There's also newer novel mind-body therapies. So some people don't do well with cognitive behavioral therapy, especially if they're really dysregulated. Their thoughts are sort of all over the place, if there's been a significant history of trauma. And that's where they may do better with what we call mind-body therapies. So that would be something like sensory motor psychotherapy or brain spotting, which I happen to have recently become trained in. Next slide, please. And for those of you who are really hoping to also get some pearls about more of the nuts and bolts about how to manage mental health, how to work people up, what medications to prescribe, I would really encourage you to become acquainted with eMental Health, the primary care. It's a great resource which lists alphabetically everything from anxiety disorder. I think it's the T is like tics and Tourette's syndrome. It's children and adults. And it takes you through from the history taking to screening questionnaires. There is also a tab on eMental Health that just lists all of the screening questionnaires you could ever imagine. The Center for Effective Practice also has lots of point of care tools. I often use the one for alcohol use disorder, and the one for adult mental health I find is really good for assessing risks in patients. And if you need a reminder for how to form a patient, there's great references there as well. And then finally, there is a tool that I just have started using in the past year that I learned about. And this is really good when you're not sure what the diagnosis is. And they're coming in with symptoms. There's something on the American Psychiatric Association website called DSM-5 Level 1 cross-cutting. And so patients fill this out themselves. It assesses various domains. And all you need to do is then just scan the ones that they have scored more highly on. And that sort of points you in the direction about, oh, maybe I should sort of screen more for OCD here, or maybe I should screen more for bipolar, or maybe this is more of a substance use, which I hadn't picked up on. And I have also given the OCFP a list of some other resources to support patients, including a handout that I adapted with breathing techniques that you could certainly share with your patients. And that's the end of my presentation, but I'm happy to take any questions.
Thank you so much for that, Dr. Skory. That was a wonderful presentation, and I already feel calmer. So thank you for that. So I'm going to go to the next slide briefly, and then we're going to take things down for the Q&A. So this is just a highlight of a resource that's available for those of you on Oscar or Accuro. Apologies to the TELUS PSS users. Yours is coming in winter 2023. This is a free tool that's been created by the Center for Effective Practice, as well as eHealth Center of Excellence. And it's a evidence to practice tool. And so what it is it's a comprehensive EMR tool that you can use to assess patients with anxiety or depression in your office. It provides practical assistance for screening and assessment, so your PHQ-9s, your grading scales, optimized guidance on management, and supports for patient self-management, like Dr. Skory mentioned. So it's a really great tool. I will disclose that I actually was one of the people who was a clinical consultant and involved with its creation, but I will say it's a very great tool, and it's definitely something to take a look at if you're interested. In addition, the eHealth Center of Excellence and the CEP offer change management and academic detailing services as well, if that's something that you're interested in terms of bringing this tool into your office. And if you feel you need more support, these are free services that are available for you as well. And so with that, I'll take down this slide, and we'll move into Q&A. So I have a few questions actually lined up for Paul. So my first question for you, Paul, really pertains to the referral process. I'm seeing a lot of comments in the chat, as well as comments on the Q&A about referring patients to the OSP program. So I'm wondering if you can confirm for us, first of all, what is the referral process, or what are the different referral pathways that one can use? Is it Ocean? Is it faxing a referral from the physician's office? Is it a patient can call and self-refer? Is it all of those? And confirm that for us. And then I have some follow-ups based on what you say.
Yeah, so thanks for the question, and there are a couple of things that I'm taking from the question. Well, the first is that we need to do a much better job of advertising and marketing this program. The referral is through the network lead organizations or the hubs. So here in Toronto, if you wanted to refer to Ontario Structured Psychotherapy Program, you go to CAMH, and CAMH has an OSP referral site. It's self-referral and direct referral. The issue around Ocean has to do with what's happening at the Royal, which is the network league organization in the East, and there they have a centralized access point which leverages Ocean, so that and we'll take this back. It sounds like Ocean is a great initiative for standardizing referrals in general, but what I'm hearing in relation to this, which is what I'm hearing from other Ontario health programs, is Ocean is great for those who have it, not so great for those who don't. So we will take that back. But in summary, you refer to your regional hub, and then they'll take it from there, including, and there were questions around wait times, including the we kind of centrally manage the wait time. So if one hub is having a long wait time, we will actually send patients to other hubs that have shorter wait times to maximize the speed. The wait times for the higher intensity services is about 78 days, which is much longer than we'd like, but much shorter than the 1 or 2 years you're accustomed to for therapy. The wait times for the lower intensity services, bounce back, internet-based CBT, which are all supported by coaches. So even though these are virtual offerings, they do have coaches helping people along with the program. The wait times for those are much shorter. And the last thing I'll say is that there was some chatter in the chat about bounce back. What's happened with bounce back is that it was in the earlier version of this program, it was kind of a separate service. We have put it behind the centralized intake, and that is also caused some disruption, but it's kind of necessary disruption for us to make this a program, so that when you refer to Ontario Structured Psychotherapy Program, you are referring to a program that then takes care of where people need to go, including bounce back, versus you having to refer to bounce back or figure out that somebody needs in-person CBT, either group or individual, virtual or in person. So it's all behind one door. Because things have changed, it's evolving over time. I'm going to ask you to for a bit of patience. We'll take back the ocean and ocean issue and talk to our colleagues in the East region to get their feedback on how we can right size that. But I'll stop there because I've gone a little bit beyond the question.
Yeah, no, but that's really helpful, and I'm glad that you're paying attention to that, because I was going to flag that there's some really great, frontline, referring physician feedback for you, like in the chat and in the Q&A as well. And I know with your leadership role, it may be helpful to know that, right? Because oftentimes these system level things can seem really great, and then once it's translated into the front line, it can become a challenge. And I would agree with you too around the ocean piece, that often what I hear as well in the front line is around the fact that if you have Ocean integrated with your EMR, it's wonderful, but that's not available to all EMR users. It's also, there's cost considerations with that as well for different offices. And if you don't have it, then it actually creates an even larger administrative barrier, right? Because now you're having to copy things from your chart manually into another system, and that actually creates more of a barrier for people. And it sounds like that's what's happening. So definitely, I think it would be great to take that back and make sure this doesn't turn into a have and have not situation based on what EMR someone is on.
Yeah. So the thing that I'm really worried about is that access to Ocean becomes a structural inequity for the program.
Mm-hmm. Exactly. So in terms of the wait times, I know you mentioned that there's different wait times before the services. Are you able to provide like an estimate in general for like what a wait time would be for one-on-one psychotherapy?
Yeah, it's not even an estimate. It is a measured wait time, 78 days.
Okay.
And we want to get it down. But right now it's 78 days. And the one thing that you have to know is that our volumes are going up and up and up, as they should. So the wait times have been pretty steady, mostly because we have been onboarding and doing more low intensity referrals. So the wait times for bounce back, internet-based CBT, and the clinician-assisted bibliotherapy, which most people should get, is lower than 78 days, but it's 78 days for the in-person or virtual group or individual CBT.
Thank you so much for that. So another question we had was about the population. So I think there were a few comments in the chat regarding children and youth and parents and that type of support. And it sounds like the service is really oriented towards 18 plus. So where do the children and families fit in?
Yeah, so this was designed from the beginning. We inherited this as an adult-oriented program, 18 plus. I can't reveal many details, but we are like I said in my little spiel, I'm very mindful of the fact that like children and particularly transitional age youth are really struggling with anxiety and could really benefit from this. And we are thinking through how we can quickly extend the age down to say 12 years of age to support youth and parents. I mean, there's a difference between parental support and CBT for adults. I don't have a good answer for how do we support parents for kids with mental illness, because there are supports out there, but it's not a part of this program. But we do want to think through access to evidence-based treatments for kids in ways that we are not currently delivering in a systematic way.
Well, thanks for highlighting that, because it's something I think that we think about from that equity standpoint again, right, around which populations are able to access it and how do we ensure that people have that healthy start as well too. So just going back to what you had mentioned about bounce back, there was something I was hoping you could clarify is around bounce back and it being like a free service versus a paid service. There's some comments here about the fact that it's that people have to pay for bounce back, which was news to me. So I just wanted to find out a bit more about that.
News to me too. The bounce back is a publicly funded service within Ontario Structured Psychotherapy. So I don't know how, I don't know why people would say it's they're having to pay for it. Within the Structured Psychotherapy Program, it is free and provided at no cost.
And in terms of another aspect here, kind of thinking about it from a population level. So one of our viewers here has said that poverty is the biggest barrier to access to mental health. And when we think about things through that social determinants lens. And so they were wondering about whether these services are linked to teams that alleviate homelessness, food insecurity, access to technology, a lot of these structural barriers and social determinants that really influence someone's mental health.
Yeah, so it's a great point, and this comes up all the time. What I will say is that there is no question that these social determinants of health impact people with mental illnesses and substance use disorders perhaps more than other individuals. The other thing I would say is we are a fledgling agency, and just standing up a CBT program is an enormous challenge. Integrating these other services, which requires interministerial collaboration, I think would drown us. The final thing I'll say is that these social determinants of health affect every aspect of healthcare. And so, for example, Cancer Care Ontario has been in existence for decades. I haven't seen much in the way of great ways that they address homelessness or income to improve access to cancer care. So, like, this is a pan-sector issue. It shouldn't be. It definitely affects people with mental illnesses and substance use disorders more so. But I feel like we need to, and across the entire healthcare sector, address these intersectional issues, rather than rely on the least well-resourced area of the healthcare system to solve it for us. But I take the point, and when we think about this, we hear about this all the time. I think we need to think about this, but please allow us the opportunity to stand up systems that don't exist before we get drowned by the intersectional stuff, which we realize is incredibly important ultimately for us to achieve the goals we intend to do. I hope that makes sense.
Thanks so much, Paul. And I know you need to run. I'm just going to ask you one last quick question, which is about the language of services. Are these services only available in English, or are they available in other languages as well?
My understanding is Bounce Back is available in a number of languages. For the in-person CBT, we certainly have Francophone availability, which is particularly pertinent for certain areas of the province. I know at CAMH we have capacity to deliver CBT in languages other than English, but I think this is going to be an equity-oriented issue as we move forward. So many things. So, and the meta message is we're just getting started. We are, right now we're very proud of the fact that, year over year, we are increasing our volumes, but we are learning as we go. What I heard in this webinar is what I know to be true, which is that this is still not as well-known program as it should be. There's a bit of stickiness and referral. None of this surprises me. It doesn't even disappoint me, because it's just a sign of the work in progress that this program is. But what I am hearing is that there's nobody saying this is a useless exercise and we shouldn't do it. So we're going to continue to work on it in the same way that we're working all of our sort of priority areas with the Center of Excellence to try to support primary care physicians and the individuals they serve with better access to services, because I know for a fact that it is not a good scene out there for you folks.
Well, thanks so much for saying that. And definitely, you have our support for this program. I think it's a wonderful program. And like you said, I think there's growing pains, and we're here to support as well with that. So hopefully today's been helpful for you to see some of those questions and that feedback. And in the future, we'd encourage you to work with us in primary care, and we're happy to help support and grow these programs so it works to care for a population. So thank you for your time today. And sorry to keep you a few minutes after 9 as well, too. I appreciate it.
Thanks so much for the opportunity to present.
It's our pleasure. So I'm just going to see here, we're going to keep going till 9:15 just to get through some more Q&A. So I'm just going to flip things back here. Gerald, actually, if I can pull you back onto the screen again. Perfect.
answering questions as fast as they come in, and yeah, I'm just not that fast a typist, folks. So.
No worries. I just had one question that came up that I wanted to flag for you again, which is just around using Paxlovid to prevent like asthma and its complications from COVID. I'm not sure if you saw that question in the Q&A come through already, but
Yeah.
you wanted to highlight that one.
Well, I think that I did answer a question that's, I think, had that as a premise. It was sort of stating a case of a 40-year-old with asthma. Paxlovid really is effective at reducing severe outcomes in non-hospitalized individuals, but I think it had something to do with should you give it to them to prevent it or something like that. I'd have to go back and look at that. I've answered about 40 questions, so it's in one of those mixes. Because I think you paraphrased it, but it's not exactly the way that it was written. And I'm trying to remember what I wrote, because I'm trying to remember how the question was stated. I'm sort of scanning through things to see if I can find it.
Oh, here, I found it for you. So a 40-year-old with asthma, could you give Paxlovid not just for hospital ICU prevention, but to prevent long COVID too?
Oh, yeah. So there was a recent study. That's right. Yeah, because there was actually a recent study. It's observational data, but it suggested that Paxlovid did not seem to have a significant impact on long COVID. I think many people on this call are probably remembering there was a study published that suggested that metformin that has not been, unfortunately, duplicated yet. So, we're getting this sort of, people are using metformin. Metformin is becoming a sort of mini wonder drug, even though I'm not a guy that prescribes a lot of metformin. But certainly in that one study, Paxlovid did not seem to have an impact on the incidence of long COVID. But again, definition of long COVID, is there they're looking at statistically significant differences. Observational studies are really problematic because there's so much confounding that goes in it. And I just mentioned that in another question I just answered, with somebody was asking me about a study that suggested if you got more boosters, you got more COVID. That's what I would call a correlation, not causation. People who get a lot of boosters may be getting a lot of boosters because they know they're at high risk for COVID, because they don't want to use any non-pharmaceutical interventions or whatever else. So, that could explain why they're getting more COVID, because the protection from getting infection really only lasts a short time, about 2 to 3 months, and disappears after that. It's just protective immunity that you get. So you got to be really careful when you're looking at these either observational data or anecdotal reports, because they're subject to so much confounding that can go on.
Great. Thank you so much for that, Gerald. On that Paxlovid front, there's a few questions about rebound. I'm wondering if you could go over that again. I know you've talked about it before, but it would just be helpful to restate that for people.
Right, and that's front of mind for people, because everybody will have seen a lot of discussion about a recent study that was just published, again, observational data, but it suggested and showed it actually reasonably measurable that people with Paxlovid tended to have longer durations of viral shedding, and that after it disappeared, it could come back again. So that's a measurement of viral shedding. In some individuals, it was associated with some persistence or recurrence of some short-term symptoms. So this whole idea of rebound, I think, has now been shown. And what it shows is it happens probably about 1 in 5 people who actually get Paxlovid. The interesting thing is, if you take Paxlovid, the time to stop viral shedding once you're infected is a lot faster than if you don't take Paxlovid. Makes sense. You're using an antiviral. So the question is does the rebound have an impact on severe outcomes? Are people more likely to die, et cetera? And it didn't show that. It just showed that, yes, if you take Paxlovid, about 1 in 5 people will get a bit of a rebound afterwards. Not all of which are symptomatic, but it can be detected by looking for virus shedding through various assays and stuff like that. So I think right now the profound effect of Paxlovid remains the issue of reducing the likelihood of hospitalization and death in people who are at risk. And so that's why our recommendation, which has come out through Ontario Health, has really continued to strongly recommend it for at-risk individuals.
Thank you so much. Dr. Skory, I have a question for you as well, if you could just pop up on the screen again.
Yeah, sorry, I was just kind of madly trying to type.
No worries at all. No worries at all. So a lot of positive feedback on your talk. People found it
Oh,
really,
good.
really helpful and
Oh,
giving
good.
them those skills. A question that we had though was with regards to, I guess, looking after yourself when you're a physician that's providing mental health care. You're going through the stresses of your clinic day. You're, all of a sudden, often, it can be blindsiding as well too, where you thought it was just a visit to check someone's diabetes, and all of a sudden they start crying in your office, and you realize that there's a mental health issue that's going on. As the physician, I'm curious, like, how do you care for yourself in those encounters? Because I can imagine, even speaking from my own experience, it's happening far more frequently than it used to. And, our population, probably as a consequence of all the things that are going on in society right now, mentally people aren't doing so well. So as a physician, I'm curious, what's your advice, or how do we handle those emotions that we might feel within ourselves as well in those times?
Yeah, so I think it's a great question and totally relatable. In the moment. So I think if we're checking in with ourselves in the moment and aware of what our reactions are, and then able to help regulate, I mean, if we just go back to our, again, sympathetic, parasympathetic system, right? So okay, lots of stress, our sympathetic system is ramped up. If we're aware of that, and if we can sort of try and provide some calm within our parasympathetic system. So for me, like when residents work with me, like one of their comments was, wow, you do a lot of deep breathing. Like I just, so whatever the story is or however dysregulated someone is, my job is to regulate myself emotionally. And through that emotional regulation, the other person is going to pick up on that subconsciously. So if I can tap into my compassion, which for me is a warm, fuzzy feeling in my heart. And that might sound really strange because it could be, how could someone be suffering and they're really distressed and I'm connecting with my warm, fuzzy feeling in my heart? But for me, that's creating that compassionate space. And then their subconscious brain is going to pick up on, this is a warm, safe place. So it's actually going to help regulate their nervous system as well. Okay, so I'm trying to produce oxytocin, nurturing, and then their subconscious is picking up, oh, okay, this is a safe place, this is nurturing. And then we give them a bit of oxytocin as well. So so I'm soothing myself, which is also going to help provide some soothing for the patient who's distressed. If I start getting distressed, or if I'm feeling their stress, now I'm getting stressed, they're getting stressed, it can really start to ramp up and no one's going to feel better at the end. I've done a lot of work personally as well. So I've done mindfulness, self-compassion, which really, so funny. I think I took the course to help my patients so I could help them with their self-compassion. And I really learned a lot about my own self-compassion. So, I mean, if anyone is feeling they could use something to soothe themselves or to learn some skills, I think that would be a really great starting point. And then just breathing. So even before you walk into the room, hands on the door, just give yourself a moment just to breathe, just slow, deep breaths, because if I'm doing a slow, deep breath, then there can't be a saber-toothed tiger in the room, right? From an evolutionary perspective.
Thanks for that. I think that's some really practical advice that people can take forward. And thank you so much for your talk. It was so helpful. And so with that, I'm going to turn things back onto the slide deck just to close up a couple of things for the session. So we can just pull up the slides again. Perfect. And I'll turn things over to Dr. Kumanan.
Yes, thanks. Just a quick reminder, we have our Practicing Well community of practice coming up on December 15th. And I think we heard a lot in the chat today about how much our admin burden and patient complexity contributes to just our workload and potentially to burnout. So this is a great session on improving burnout, specifically looking at time management. And there's a link to register on our website. Next slide, please. And then just one more reminder, we have our Family Medicine Summit coming up on January 26th, 27th. This is our conference. It is going to be held virtually with some live stream days and then access to sessions afterwards. So we've got some great keynotes and sessions planned, and I'd encourage you to check it out.
And so with that, that brings today's session to a close. I hope you all enjoyed the new format. And again, if you have feedback, please fill out the survey so that way we know whether or not this new type of format with having more of the Q&A at the end was helpful. And again, the recording and the curated Q&A will be posted soon, along with some of the resources that were discussed for today. Our next Community of Practice will be on December 15th, 2023, and we're looking forward to seeing you all before the end of the year. Thank you again for your participation and have a wonderful weekend. Take care.